Thank you for joining my presentation on pulmonary function testing in the neuromuscular patient. My name is Terrence Shenfield, and I've been an education coordinator for the last 30 years. I worked at a major trauma center. I was also in charge of the pulmonary function lab, and we had plenty of patients who had neuromuscular disorders that we had to do pulmonary function testing on. Progressive neuromuscular disease leads to muscle weakness or failure that produces a loss of pulmonary function and clinical respiratory morbidity. So tracking pulmonary function is a very practical way to actually determine what stage of the disease they are at. So you can offer additional support to them if needed. By the end of this presentation, you're going to have a good handle on the pulmonary function tests that are involved with neuromuscular disorders, and I'm also going to go over certain kind of conditions that sort of refresh you with. I hope you enjoy this presentation. The objectives of today's presentation is number one, to describe neuromuscular disorders that impact breathing. Truth be told, most neuromuscular diseases have some kind of manifestation in pulmonary function. So as someone gets more along in their disease process, you could really sort of tell how they're depreciating by doing PFT tests. I'm also going to be talking about some different types of pulmonary function tests that can be used in the management of these patients. We could sort of do serial PFTs on them to see if their disorder is sort of stagnant or if it's really going anywhere. I'm going to describe some tests commonly used at the bedside because not all pulmonary function testing is done in a lab. A lot of times patients who are at the bed, we do bedside spirometry on them, and we could do peak flows. We could do a whole host of things with them at the bedside. And from my experience, I worked at a major trauma center, and we had a neuromuscular disorder expert there. His name was Dr. John Bach. And a lot of patients across the country would come to our facility, and we, as respiratory therapists, were sort of tasked with doing all these kind of bedside spirometries with them. And then I'm going to describe some studies on this topic to sort of keep you really informed of what's going on. So I think you're going to really like today's presentation. So what kind of neuromuscular disorders impact breathing? And I have right here a short list of different types of disorders, and I'm going to get into each particular disorder a little bit later, but this is just a snapshot of what's coming. I'm going to be talking about ALS, I'm going to be talking about multiple sclerosis, I'm going to talk about muscular dystrophy, I'm going to talk about myasthenia gravis, I'm also going to be talking about Guillain-Barré, and Guillain-Barré has a soft spot with me. My son, I have a son named Terry, he came down with Guillain-Barré out of the blue, and he was sort of was feeling like numbness in his feet, and it sort of progressed up his legs, almost to a point where he was bedridden. And thankfully, this neuromuscular disorder actually stopped at the legs rather than reaching the diaphragm. A lot of patients with Guillain-Barré can have their diaphragms paralyzed, requiring mechanical ventilation. The good news is that he fully recovered, but it took about 3 years for him to recover. So I'm going to get a little bit more into Guillain-Barré. I'm going to talk about spinal muscular atrophy. Spinal muscular atrophy, as I was telling you before, one of our physicians on staff, Dr. John Bach, he was an expert in this particular field. This really impacts young pediatric children. And the funny part with these children, a lot of them are on non-invasive ventilation. That's how they breathe. Also, these patients, this is off the topic, but they had the most beautiful eyes. They suffered one way, but they looked like angels. And then I'm going to talk a little bit about chronic inflammatory demyelinating polyneuropathy, CIDP. So I'm going to get into all of these disorders. I'm going to go like a little bit more detail on each one. And then I'm going to talk about different types of pulmonary function tests or bedside spirometry, which can be used to manage these diseases so you could sort of see the progression of them. Hope you like this. Let's talk about the effects of neuromuscular disease on the respiratory system. It impacts different parts of the respiratory system in different ways. For example, you have a decrease in respiratory muscle strength. You can have a dysfunctional cough where you don't get enough air in your lungs to actually have an effective cough, or your abdominal muscles are not strong enough to expel retained secretions. You could have sleep abnormalities. You could also have a reduction in respiratory system compliance. So let me go a little bit more into respiratory muscle strength. For example, each neuromuscular disease has a different and specific natural history. And this can be seen with multiple types of diseases. The most common test to determine muscle strength of the lungs is to do a vital capacity. A decrease in vital capacity is an indicative of the patient getting worse. So a vital capacity is a very good test to determine inspiratory strength, and it's actually a very good test to determine the progression of their disease. Measurements in respiratory muscle strength are important over time. So it's not just like you do a snapshot of this one time. You need to do this over a period of time to see if there's any kind of decrease going on. So let's talk about the core function. You know, impairment of a core function is a very common thing in neuromuscular disease, and is caused by both inspiratory and expiratory muscle weakness, as well as an impaired glottic function. So a reduction in inspiratory muscle strength leads to a reduction in the volume of intrathoracic gas available to remove secretions from the airway. If you don't remove the secretions from the airway, it predisposes you to respiratory complications, including bacterial infections. So a good core function is important. To measure core function is very important in this population. So let's talk about sleep abnormalities. Sleep abnormalities are very common in this particular population. Hypoventilation syndrome, central apneas, obstructive events are all seen in this group of patients. Sleep disoriented breathing tends to increase with decreased vital capacity due to respiratory muscle weakness. So as your vital capacity worsens, so it increases your sleep disorders. They go hand in hand together. Kind of sad, but that's the way it is. And finally, we talk about respiratory system compliance. A lot of times, patients with neuromuscular diseases have a reduction in respiratory system compliance. This is due for several reasons. The progressive loss of respiratory system volume results in alveolar collapse and microatelectasis, which actually reduces lung compliance. So these are some of the common indicators, some of the common themes that we see with neuromuscular disease. We have a whole host of different types of pulmonary function tests that can be offered in the laboratory as well as the bedside. Some of the most important ones are lung volumes. Lung volumes can be measured in the body box. It can be measured by gas dilution, or it can be measured by nitrogen washout. Lung volumes are related to body size and height as being the most important variable. It's very similar to spirometry, and we're going to get a little bit more into spirometry, but lung volumes, such as measuring the total lung capacity or looking at the residual volume, can be very important in determining how far along someone is with neuromuscular disorders. So lung volumes are really important, and we're going to talk more about that a little bit later. Another very important feature of a bedside spirometry would be peak core flow. Peak core flow is very important in relation to coughing. Why is coughing important? Coughing is important because you need to mobilize secretions that are in your lungs that could be potential pathogens. So the typical cough consists of the following sequential steps. Basically, you take a full inspiration, you have closure of the glottis, you have the contraction of the abdominal and expiratory muscles, and then you generate a positive intrathoracic pressure. And then when you open the glottis, this allows for forceful expulsion of gases. So peak core flow is a very, very important test for this population. Spirometry is another very important test. Basically, when we do spirometry on these particular patients, we are looking at the FEV1 and we're looking at a forced vital capacity. And typically, FEV1 and forced vital capacity are both reduced in this population. And this is a component of expiratory muscle strength and chest wall and lung compliance. That is the problem with these particular patients. So measuring FEV1s, forced vital capacity, FEV1 over FVC is really important to understand these ratios. With that, forced vital capacity is another very important test. So some other tests that we do is to determine respiratory muscle strength. We will do what is known as a maximal inspiratory pressure, MIP. We'll do a maximum expiratory pressure, MEP, and we will also do a maximum inspiratory capacity. All of these tests determine the strength of the lungs, they determine the strength of the abdomen, and these are really important, especially with this group of patients. Total lung capacity consists of different types of volumes. It consists of tidal volume, which is the amount of air that's inhaled or exhaled during a normal respiratory cycle. It also consists of inspiratory reserve volume, which is the amount of air that is forcibly inhaled after a normal tidal volume. Inspiratory reserve volume is usually kept in reserve, but is used during deep breathing. The normal adult value for IRV is approximately 1900 to 3300 milliliters. Then you have what is known as expiratory reserve volume. This is the volume of air that is exhaled forcibly after exhalation of normal tidal volume. The normal adult has anywhere from 700 to 1200 milliliters of ERV, but ERV is reduced in obesity, ascites, and any kind of upper abdominal surgery. And finally, we get what is known as residual volume. It is the volume of air remaining in the lungs after maximal exhalation. Normal adult values is averaged to be anywhere about 1200 milliliters or anywhere from 20 to 25 milliliters per kilogram. It's indirectly measured from the summation of FRC and ERV, and it cannot be measured by spirometry. So these are different lung volumes. They're all important to understand pulmonary function test, and a lot of these are part of the tests that we do with the neuromuscular patients. Total lung capacity is comprised of vital capacity and residual volume. Volume capacity is typically low as a result of loss of inspiratory muscle strength, in addition to a decrease in lung compliance, which most likely is caused by diffuse microatelectasis. And also the chest wall compliance is typically lower due to scoliosis. A lot of these patients end up getting curvature of the spine. Residual volume, which is the volume of air that remains in the lung after maximal expiration, is determined by the ability of the expiratory muscles to compress the chest walls inward. An increase in lung recoil is associated with low values for FRC and RV. RV is determined by the ability of the expiratory muscles, again, to compress the chest wall inward. So as the expiratory muscles squeeze the chest wall, it lowers the RV. But as muscles become weak, the RV will normally increase. In neuromuscular weakness, total lung capacity is typically low, functional residual capacity is normal, and RV is high. And why is the RV high? It's high because the patient doesn't have the ability to compress the chest wall and remove all the air. So this is a little bit how lung volumes become very important in this population. The peak flow rate is a very simple test to do, and it's rather inexpensive. It can be done at home, it can be done at the bedside, it can be done anywhere. And basically, patients with neuromuscular diseases have a decrease in peak flow values. So it's a good indicator of how they're progressing. A lot of times the peak flow rate was used in asthmatic patients and COPD patients, but it really applies to this population too. The problem with the peak flow rate is that it's effort dependent. In other words, the patient really needs to be able to take a deep breath and then blow out as hard and as fast as they can. Sometimes they, instead of doing a peak flow rate, they will do actually what is known as a CPF, which is a cough peak flow. And a lot of times with this particular method of determining a peak flow rate, it could actually minimize effort and it could give you better results over time. Patients with neuromuscular disease, cough peak flows are better than actually a peak flow meter, and because it's a great way of measuring the expiratory muscle strength. It's basically rather inexpensive. It can be done at any place you want. And you could also do what is known as an assisted cough peak flow, where basically the patient air stacks. In other words, they take little breaths, deep little breaths, they stack it, and then what they do is they give you a little abdominal thrust. So in other words, as the patient's ready to exhale, they actually push on the abdomen, and you can get a better value. The difference between an assisted and an unassisted CPF can be used to measure glottic integrity. So glottic integrity can change in each type of case. Let us talk about a peak poor cough flow in a little bit more detail. Coughing is an important respiratory defense mechanism that clears potential pathogens and maintains airway patency. A typical cough consists of the following sequential steps. Number one, you got to take a full inspiration. Number two, you have to have closure of the glottis. Number three, you need to have contraction of the abdominal and expiratory respiratory muscles to generate a positive intrathoracic pressure. And then number four, you open the glottis and to allow a forceful expulsion of air outward. That is your typical peak cough flow mechanism. And it's so important to measure peak cough flow because this can determine whether the patient has the ability to maintain a patent airway by mobilizing secretions that could potentially cause harm to the patient. Patients with neuromuscular disease normally have a very weak cough as a result of absent or reduced respiratory muscle strength. In addition, those who have associated bulbar dysfunction may also have a weakened cough because of the inability to rapidly open and close the glottis, and this can result in ineffective coughing. So the peak cough flow is a great tool to be done at the bedside. It is used to assess respiratory muscle strength, and actually it's measured in liters per minute. So this is a very important tool to keep in this particular population. This is an example of the device that can be used to measure peak cough flow at the bedside. Rather simple test, and some of the indicators, a lot of studies have shown that if your peak cough flow value is less than 160 liters per minute, it shows to be a good predictor that you have an ineffective cough and that you are likely to develop some kind of lower respiratory infection. So this is just a quick picture of it, just based upon what we were talking about. Among the various types of spirometry tests done on patients with neuromuscular disease, the forced vital capacity or the slow vital capacity allows assessing the extent and the following of decline over time of restrictive patterns known with these neuromuscular diseases. So When someone declines in their forced vital capacity over time, it's basically an involvement of the diaphragm and different types of respiratory muscles. The reduction in forced vital capacity in neuromuscular disease is also an early indicator of the appearance of hypercapnia. Hypercapnia can be defined as an increased value of carbon dioxide in the blood. And when this happens, this further deteriorates the quality of life and results in using non-invasive mechanical ventilation when necessary. When the forced vital capacity is reduced to below 60%, you need to do some kind of form of sleep oximetry on these patients to be performed annually, because you really need to monitor this. And what happens if the values fall below 40%, then you need to do additional tests. And like I said before, you might need to do some form of non-invasive ventilation. Forced vital capacity greater than 20% or forced vital capacity reduction greater than 20% measured in the supine position as compared to a normal FVC means that the patient has very weak diaphragm. So this is like a hallmark test that you could do in the supine position versus the sitting up position. If you get a drop in 20%, you know, this represents a real problem. So again, the forced vital capacity is a great test to use, and it tells you tells you volumes of information. Two common tests done at the bedside or in the laboratory is the maximal inspiratory pressure or the maximal expiratory pressure. Both of these tests are a great test to determine the respiratory muscle strength. And the difference between the both is one is done when the patient inhales, and the other one is done when a patient exhales against a closed shutter. So as you breathe out, you measure the MEP. As you breathe in, you measure the MIP. These are great tests to determine if there's any kind of decrease in respiratory muscle strength. Some of the key factors here, which is really kind of cool, is the fact that the MIP is a great predictor of diaphragm weakness before you see any kind of spirometry changes. For example, you could see a normal forced vital capacity, but if your MIP is decreased, you can see that the diaphragm is actually weakened, and it's more sensitive than actually spirometry tests like an FVC. So these two tests, MIP, MEP, are very important at the bedside, and you should really know about that. And sometimes they test different neuromuscular diseases based upon the condition of the patient. This is a little bit more on MIPs and MEPs. Like I said on the last slide, they are really, really good for predicting respiratory muscle strength. So in other words, as a patient's condition worsens, you will see a decline in both values. The MIP is really a great test to determine the inspiratory pressures of the patient, where the MEP is a great test to see your expiratory pressures. So the difference is this: if someone has a decreased MIP, it's mostly indicative of a weakened diaphragm, where if you have a weakened MEP, it's more the accessory muscles, the abdominal muscles that are in place. So as you can imagine, when someone inhales, the diaphragm goes down, and if your diaphragm is weak, you're going to have a poor MIP. And then the MEP is if the patient exhales, that really sort of takes a little bit intercostal muscles. It also requires your abdominal muscles to exhale. So these are both great tests, and there's a lot of studies showing that these decrease, there's an indicator of mortality. So you should know these tests. As I was mentioning before, MIP and MEP have been involved with survival studies. In other words, when patients have neuromuscular disease, these are one of the most common tests that could predict the mortality of the patient. And you know, there are different values based on different types of neuromuscular diseases where this occurs, but you should be aware that when you think about MIP and MEP, they look at survival survivability of the patient, how long they're going to survive. Because if these markers go down real quick, you can imagine the patient's condition is going to failing rather quickly. So just be aware of this. I wanted to go over some case studies with you where they did some studies of MIP and MEP versus forced vital capacity on survivability of ALS patients. And I'm not going to read them all to you, but I'll read the first three. They did a cohort study of 95 patients with ALS, and they found a significant association between the MIP and 1 year survivability. The study found where if you had a greater than 80% predicted of forced vital capacity, you had an 80% chance of survivability in 1 year. But if you had a normal MEP or MIP, it predicted a greater than 90% chance of survivability. So the sensitivity of this test, the MIP and MEP, was greater than the forced vital capacity. In the second study, they looked at reduced MIPs predicted a poor 2-year survivability rate. So again, MIP is utilized in determining how long these patients will survive, especially with the ALS patients. And then finally, I'll just mention the third study where they had patients who had an MIP of less than 60 centimeters of water. This was 100% sensitive as a threshold for predicting 18 months survivability, where the forced vital capacity was not as sensitive, and it showed a predicting survivability rate of 80%. So you have 100% sensitivity versus 80%. That means that the MIP is much more sensitive test to determine survivability. You can read the other two studies for yourself, but the point here, don't underestimate the MIP and MEP test in regard to patients versus forced vital capacity. Don't just limit yourself to a forced vital capacity. Before we get much further, I wanted to explain a couple of different methods that is used for lung insufflation with neuromuscular disease. And the two techniques that are commonly used is one is called air stacking and the other one is called maximum insufflation capacity, MIC. And both of these techniques work kind of well with each other, but one is a little bit better than the other. So let me tell you which one each one is. For example, in air stacking, this is when a person is encouraged to take deep, slow breaths, stacking one breath on top of each other. This technique allows the lungs to actually fill with more oxygen. It actually encourages a patient to breathe slowly. And the point is this, that you need to stack these breaths with a closed glottis. And then you hold like an inspiratory hold with it, and then you exhale. So this is a very good method to actually, you don't need any equipment. And all you got to do is take some deep, slow breaths, and then hold it, then stack another breath on top of it, hold it. But, obviously the glottis needs to be fully functional. In regard to the maximum insufflation capacity, MIC, basically it's the same kind of process where you're going to stack breaths, where your air stacking is achieved by telling the patient to take a deep breath, holding it, and then stacking breaths on top of that. The difference is with maximum insufflation capacity, you're using a manual resuscitator to actually do this. So one is done passively just with room air in your mouth, and the other one is using a manual resuscitator. And studies have shown that one is a little bit better than the other, but if you don't happen to have a manual resuscitator handy, the air stacking technique works rather well.
Okay, Greg, we're gonna do breath stacking now with the manual bag, okay? So what I'm gonna do is I'm gonna place this in your mouth and we're gonna give you 5 big breaths, okay? So I'm gonna remove this.
Okay, yep.
Okay. Breath 1, breath 2, breath 3, breath 4, breath 5, and breathe out. Okay. Back up. Okay. And Greg, your volumes with the manual bag are 4.16 liters.
So now that we learned a little bit about lung insufflation techniques, namely you have passive lung insufflation, which is basically air stacking. Then you have other lung stuff, maximum insufflation capacity, which is done with a resuscitator. They found that the patients who benefited the most came from maximum insufflation capacity, which is done with a an ambu bag. What they found was that they could actually do quantifiable assessment of glottic integrity by comparing vital capacity measurements. And the patients who benefited the most from this technique were those who had the lowest vital capacity. So the point here is to show that, lung insufflation capacity is a great tool. It's nice to do it if you have no other tool. You could do some air stacking, but if you have the ability to have some kind of resuscitator, which is not that difficult. I mean, I can imagine you could have a resuscitator at home and you stack your breaths that way via MIC, you get a much better result from it. So let's start talking about different types of neuromuscular diseases and what kind of pulmonary function test could benefit this particular disorder. Some of the neuromuscular diseases I'm going to be talking about is ALS. I'm going to be talking about multiple sclerosis. I'm going to talk about muscular dystrophy. I'm going to talk about myasthenia gravis. I'm going to talk about Guillain-Barré. I'm going to talk about spinal muscular atrophy. I'm going to talk about chronic inflammatory demyelinating polyneuropathy, or commonly known as CIDP. So I'm going to cover all these topics. I'm going to talk about what kind of pulmonary function tests benefit, either it's in the laboratory or if it's in the bedside. And we'll cover each one, and we'll go a little bit more detail about each one so you get a little better background. We'll start with a very common neuromuscular disorder, amyotrophic sclerosis, or ALS. Another name for ALS is Lou Gehrig's disease. This is a rare neurological disease that primarily affects nerve cells responsible for controlling voluntary muscle movements. These muscles produce different features like chewing, walking, talking, and breathing. The disease is progressive, meaning that the symptoms get worse over time, and currently there's no cure for it and there's no effective treatment to halt it or reverse the progression of the disease. Basically, ALS belongs to a wider group of disorders known as motor neuron diseases, which are caused by gradual deterioration and death of motor neurons. Motor neurons are nerve cells that extend from the brain to the spinal cord to the muscle throughout the body. As the motor neurons degenerate, they stop sending messages to the muscles, and the muscles gradually weaken, start to twitch, and waste away, which is another word for atrophy. Eventually, the brain loses its ability to initiate and control voluntary movements. So when you have ALS, the key point that you need to do is you might have to support ventilation, eventually with non-invasive ventilation. Another concern with these patients is what is the most common pulmonary function test? What you do with this, and typically it's a forced vital capacity. More people do forced vital capacity measurements with ALS than any other pulmonary function test. Why, I don't know, but I could just say that, and especially with the evidence I've shown before, where the MIP and MEP are great predictors. But with ALS, the typical test you get is a forced vital capacity. Multiple sclerosis is an autoimmune type of disorder. And the impact of multiple sclerosis is that there's a myelin sheathing around our nerve cells. And when you think about a myelin sheathing, think about an electric circuit, like where you have a copper wire and then you have a plastic outer, plastic membrane around the copper wire. Our immune system detects that as a foreign body and attacks that sheathing. As a result of that sheathing being destroyed, signals from the axon cells are all lost, and so what happens is you end up having a loss of muscle tone, muscle weakness, and actually you have physical impairment. The respiratory muscle weakness can produce a restrictive breathing pattern on spirometry. So if you do any kind of spirometry, you will find a restrictive pattern. And then this could actually lead to respiratory failure. Respiratory complications are common in the terminal stages of this disease because the patient has an impaired respiratory system. And kind of funny, or it's not funny, but the expiratory muscles have been shown to be reported more affected than inspiratory muscle strength. So what does that mean? When you think about inspiratory muscles, you're thinking about the diaphragm. So the diaphragm sort of functions fairly normal, but the other muscles that are a part of exhalation, like your intercostals and your abdomen muscles, they become weakened, so you really can't cough. What that can cause is that, if you can't cough, you're not going to be able to remove secretions from your lungs, and you're predisposed to getting some kind of a respiratory disease or some kind of bacterial infection. These patients are really severely damaged. A lot of times they're in wheelchairs. They need assistance. I personally work at a rehab hospital where there's a lot of patients who we have a whole wing where they actually live. And so they're not really patients, they're residents. They live there, and a lot of them have neuromuscular diseases, especially multiple sclerosis. And they are wheelchair bound. They have problems with their breathing. They need non-invasive ventilation at night. And so the most common test for them is they actually do a diffusion capacity test with them too. It seems like that's impaired too, to a certain degree. Forced vital capacity is another one. Total lung capacity is another test. So FEV1s. So all of these tests are impacted with multiple sclerosis. So that's how multiple sclerosis is managed. I'm not telling you how it's managed, but I'm telling you what kind of pulmonary function tests are ordered with it and a little background on what it is. Muscular dystrophy is a group of diseases that cause progressive weakness and loss of muscle mass. Basically, it is a genetic disorder. What happens is there are abnormal genes or mutations that interfere with the production of proteins that are needed to form healthy muscle. So due to this genetic condition, proteins are not produced that would normally be used to build healthy muscles. And as a result, you have muscle wasting. There are several types of muscular dystrophy. There's one called Duchenne's type, which is the most common. It mostly impacts males than females. It is a progressive weakness and degeneration of skeletal muscles. It impacts all races. It's not just necessarily one race over another. As the skeletal muscles become inactive, there's a lot of problems with the diaphragm. So sometimes the diaphragm can't pull in. So inspiratory breaths are really impacted. So some of the tests you want to do with it is you want to do, forced vital capacity or slow vital capacity. This is the one disease that really gets the whole smorgasbord of different pulmonary function tests. They've done forced vital capacity with this. They've done some cough peak flows with this. We talked about that before. We also did some measurement of muscle strength, which is such as the MIP and the MEP. Also, they do what is called the peak cough flow. They measure that because, again, a lot of problems with this is if you can't take a good breath and you can't mobilize secretions from your lungs, number one, you're going to be predisposed to some kind of, bacterial infection in the lungs. And eventually, when you can't take deep enough breaths, you're going to get hypercapnia. And if you start getting that, that's when they start putting you on non-invasive ventilation, which can probably progress into, full-time mechanical ventilation. So this is a very severe condition. There are ways to slow down the progress, but they really haven't found any cure for it. So muscular dystrophy is one of those neuromuscular conditions that require a whole host of different testing to go along with it. Myasthenia gravis is a chronic autoimmune disorder in which the antibodies in our body destroy communication between nerves and muscles. This results in weakness of skeletal muscles. It mostly impacts people who are greater than 60 years old, and one of the first telltale signs of myasthenia gravis is that you have drooping eyelids. Also, this works into weakness of the arms and legs, and then you might also see a change in voice, and you might even see drooling. You might even see, they have a problem with swallowing. They'll drool. So these are the common findings, but then it could really progress into the pulmonary system. Some patients have ended up being intubated as a result of this, and there's currently the incidence is anywhere from 0.3 to 2.8 per 100,000 worldwide, with a prevalence around 700,000. They did impact an effective treatment long ago. It's called cholinesterase inhibition, and that has worked very well as a treatment for myasthenia gravis. Some of the pulmonary function tests that you want to do with this condition is a vital capacity, an MIP, and an MEP. Studies have shown that a vital capacity of 15 to 20 milliliters per kilogram or maximal inspiratory pressure of less than 25 to 30 is often cited as a cutoff point for intubation. Some of these patients end up being intubated, and this is like some kind of telltale signs of what you're looking for if you happen to do a vital capacity or an MIP on these patients. Guillain-Barré. Guillain-Barré is something that I personally have experienced within my family. My son Terry, who was probably about 26 years old, he doesn't know where it came from, but whatever happened, he started with getting some tingling of his feet, worked up to his legs where he couldn't even move his legs, and he ended up being bedridden for a couple of weeks. And it stopped. It could work its way right up to the diaphragm, where a lot of these patients end up being on mechanical ventilation. But in his case, it stopped right at the legs, and then it worked its way down. Basically, he's fully recovered. But I ended up learning and researching so much about Guillain-Barré because, it's my son. Of course you would do that. The estimated incidence of this particular case is 1.65 to 1.79 per 100,000 cases. And I don't know if my son was one of those statistics. It's believed to be an autoimmune response that attacks nerve cells. Typically, they think it's triggered by some kind of respiratory infection. It could be also, they've been talking about if you get immunizations, you could be triggered by that. It also could be triggered by surgery. They don't know exactly what's going on with it, but the most common form of this disease is acute inflammatory demyelinating polyradiioneuropathy, and that's how it causes progressive motor weakness. It seems like a lot of these neuromuscular disease result in demyelation. What that means, remember I was telling you about the myelin around the nerve cells? For some reason, many of these conditions, that myelin sheathing that's around the nerve cells gets destroyed, resulting in you can't really send good signals to your muscles from the brain. And the most common form of this disease is called acute inflammatory demyelinating polyradiioneuropathy. And they have symptoms typically last for a few weeks, and sometimes they plateau. In my son's case, it never really worked into the lung, but some of these patients, it goes right into the lung and it goes right into the diaphragm. So what do you have to measure? If you're concerned about the diaphragm not working properly, a vital capacity is one of the best tests you could do on this. And so what you do is you do a vital capacity and you look to see, how far it's dropping over time. And a lot of times these things, you don't even have to give any kind of treatment. There's really not much treatments out there for this, but you could just, it self-corrects in itself. Most people who have Guillain-Barré recover. Some people have deficits. In my son's case, he did very well and he has no deficits from it, but it was a very scary part of my life. Spinal muscular atrophy. Spinal muscular atrophy is a disorder that is a genetic disorder and is characterized by degeneration of the anterior horn cells, resulting in muscular atrophy and weakness. There are various types of SMA. They got type 0, they got type 1, they got type 2. And from my experience working at a major trauma center in Newark, New Jersey, one of our doctors, Dr. John Bach, he was a world leader on SMA. He was someone who everyone flew their children into from all over the country and also all over the world. We had patients from England, Egypt, everywhere across the world. And it's very sad to say that a lot of these, from my experience, was the SMA type 1. By the age of 1 year, they needed some form of assisted mechanical ventilation to breathe. So basically, we used to use nasal pillows on them for them to breathe. The likelihood of getting this is 1 in 11,000. The severity of SMA it all depends on what type you have. There's a lot of details into this, so I can't really go into that. Currently, there's no cure for SMA, but they found methods to actually reduce the progression of the disease. But they also, like I said, SMA type 1, typically by the age of 1 year of age, you're on non-invasive ventilation. So your lung function deteriorates to a point where you can't breathe on your own. So they do non-invasive ventilation with them. Just a side note, I've worked with these patients many times, and for some reason their bodies are a little bit deformed from this SMA. They like sort of curled up and they retract, but they have the most beautiful eyes. They have angel eyes. It was, hard. It was very hard working with these patients. But the family loves them and they receive the best of care. SMA type 1s, when I first started working with them, they would potentially expire within 2 to 3 years. But right now, due to different technologies and different treatment plans, they have been extended in life. And so I've seen some much older than 1 year and even like up to 10 years, 11 years, 12 years of age. But probably most likely they're going to be on some form of non-invasive ventilation. In regard to pulmonary function, one of the most common tests with them is the MIP and MEP. They really don't do much about spirometry with them. I think they're a little bit too weak, but the MIP and the MEP was well used, and a vital capacity was used at the bedside using some kind of spirometer. So this is it's not that common, but it does happen, and it's very sad, and that's all I could say about it. A final neuromuscular disease is chronic inflammatory demyelinating polyneuropathy, commonly known as CIDP. Chronic inflammatory demyelinating neuropathy is a condition that arises from the myelin sheath around the nerve cells that are damaged. It seems like a common theme that most of these neuromuscular disease impact the myelin sheathing. In this case, the myelin sheathing is an insulating layer of tissue that surrounds nerve cells that helps ensure signals from the brain that are rapidly transmitted to other places in the body. This myelin sheathing has some kind of inflammation occurring to it with this CIDP. So due to the inflammation, what you have is impaired muscle weakness and muscle tone and control. Many of these patients have general weaknesses. They also have impaired sense of touch, and the condition progresses. It could lead to muscle atrophy and spasms, difficulty swallowing, difficulty talking, difficulty with in coordination. Not often, but some cases have led up to the diaphragm, where you need to have some form of assisted ventilation. Most likely it's going to be non-invasive ventilation. So this disorder is commonly mistaken for Guillain-Barré syndrome. It's kind of close, but there is differences. I'm not going to get into the technical aspect of what makes it different, but it is sometimes thought as being Guillain-Barré. It typically gets better within 2 months. So it's short acting. It's like something that doesn't last a lifetime. It comes on you, you get this muscle weakness, and then you get better. In cases where it impacts the diaphragm, a vital capacity is one of the fine tests that we do for these patients to determine that they don't need any kind of assisted ventilation. So this is the last of my what you call neuromuscular diseases that you need to know about, and hopefully you gained a lot of information from it. I want to thank you all for joining my presentation. I hope that I sort of explained different pulmonary function tests that are used in the neuromuscular patients. There's a whole host of different type of pulmonary function tests that can be done in the laboratory as well as the bedside. Each one of them have their own merits. And also when you apply them to different types of neuromuscular diseases, you could sort of gather different information. The common theme to this is that it's very important to monitor the lung function. So PFTs and neuromuscular diseases goes hand in hand. We really need to apply everything we know so that they understand what's going on and how the disease is progressing. So many studies are out there showing that if you do different types of spirometry tests and MIPs and MEPs, you could determine survivability, which is really kind of relative. People want to know how long they're going to survive, and also when you need to have an intervention such as non-invasive ventilation, because a significant part of this population end up being on non-invasive ventilation. When you think about these patients, not all the tests are done in the laboratory. Sometimes you need to do tests at the bedside. So bedside spirometry, bedside testing, having the therapist have the knowledge to conduct these tests is really important. And remember, the more you know about neuromuscular diseases, the more you know about spirometry tests, the more you know about different tests predicting survivability, the better therapist you could become. I want to thank you all for joining this presentation. I know I could have went into a lot more depth with it. I didn't realize how deep this was. I sort of blaze through some of the topics, but I wanted to cover these things just as an eye-opener. And I'll probably put a new presentation, I'll put a new presentation together that will cover more details about each particular condition. So I put together some references for you. As I mentioned, John Bach, he's right at the top. This guy has been a pioneer in the field of neuromuscular disease, especially with the use of non-invasive ventilation. I've told you a little bit of my own experience about Guillain-Barré from my own family. These are other resources. And, understanding these conditions and what you do about them is really important. And I want to thank you all for joining me, and I hope you have a great day.